Good afternoon and welcome to Baptist Health International's quarterly medical lecture. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation this afternoon. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone that is joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A features located in the bottom of your screen. Our moderator today will be our very own Dr. Rogelio Rivas, our Corporate Vice President at Baptist Health International. This afternoon, I have the pleasure of introducing Dr. Raymond Leveillee, who is the Medical Director at Baptist Health Bethesda Hospital Center for Advanced Robotics and Urologic Care. His presentation will be Update on Management of Renal Masses from Needle to Robotics. Dr. Leveillee is a urologist and member of the Baptist Health Medical Group North. He specializes in providing complex urologic care for a variety of medical conditions, which includes prostate cancer, kidney cancer, and stone disease. Dr. Leveillee received his medical training at Brown University Alpert Medical School in Providence, Rhode Island. He completed his residency training in Rhode Island Hospital and fellowship in endourology and laparoscopy at the University of Minnesota in Minneapolis, Minnesota. Before joining the Baptist system in 2015, Dr. Leveillee taught at the University of Miami's Department of Urology and was tenured professor of urology, radiology, and biomedical engineering, as well as the chief for the division of endourology and laparoscopy. His clinical and research interests includes robotic surgery for kidney, urethra, and prostate cancer, reconstruction, complex stone treatment, and minimally invasive techniques for terminally ablating kidney tumors. He recently published a textbook on renal mass biopsy back in 2020. Among his numerous honors, Dr. Leveillee was appointed to serve on the committee of the American Urological Association for Kidney and Adrenal Health. Dr. Leveillee has published over 130 peer-reviewed articles, several dozen book chapters, and has served as a reviewer for several publications. He has been an invited lecturer on both national and international conferences. He's a member of the American Urological Association, the American Association of Clinical Urologists, and the Society of Robotic Surgery. Please, let's give a warm welcome to Dr. Raymond Leveillee. Thank you, Dr. Leveillee, for accepting our invitation and for this wonderful conference that we are about to hear.
Thank you very much, Dr. Hakim, Dr. Rivas, and all of those that are joining us on this webinar. I apologize for the lengthy introduction. We needed to leave some time for the actual lecture. So, Dr. Hakim, thank you for struggling through that long intro. I'm going to go ahead and switch over and share my screen now. And the topic today that we're going to cover is near and dear to me. It's one that I've been actively involved with for many years, and that is, how do we deal with these renal tumors as time has gone by over the course of my not only collegiate medical training and academic career. Things change as we get older. So what I want to do first is just give you a broad 30,000 foot view of what we're going to cover. And renal masses come in many different sizes. So we'll talk about the differential diagnosis, the treatment options with the abbreviations AS for active surveillance, implying that not all patients with renal masses need treatment, radical nephrectomy, RNX, partial nephrectomy, and then TA's a global term for thermal ablation, whether it be freezing, cryoablation, heating, and I'll not have adequate time to delve into all of the differences of these, but perhaps question and answers or follow-ups later via email. I'd be happy to entertain those type of questionings. And I really want to stress the importance of imaging radiology in terms of diagnostics, but also therapeutic interventions. I just turned 58 on Saturday. And I look back at my experience when I was in training, this was the only way to do any kind of surgery, was with a scalpel, a large flank incision for kidney surgery, and staples. And over the course of my career, I've seen the introduction of standard laparoscopy, hand-assisted laparoscopy, robotics, and even non-robotics internally deployable methodology. And what I think about is that when I was a young man, I could never have imagined what an iPod would be. No one conceived of Uber, DirecTV, or anything that we currently take for granted, such as microwave ovens, SunPass, computer monitoring. And so when you think about it, the ability to think about your medical training really has a lot to do with advances in communication, satellites. I think we're going to see a lot more in the future with computer algorithms, artificial intelligence, not to replace us as physicians, but to augment what we do. Renal cancer is what we're going to focus on next. It's a fairly high incidence with 65,000 new patients estimated per year in the United States, with 13,000 deaths. There is a correlation between the size of the mass and the malignant potential, but not necessarily the grade of the tumor. And what often was considered to be the gold standard, radical nephrectomy, is no longer for most instances of small and medium-sized masses. So traditionally, this was the triad that we would see: a thin male with gross hematuria and a palpable mass. And now with the increased use of cross-sectional imaging, there's hardly a patient in our emergency room that doesn't get a CT scan or an ultrasound when they come into the ER with abdominal pain. We find that 80% of the masses that are found by accident for other reasons. Just to put it in perspective, the first planned nephrectomy was done in 1869 by Gustav Simon, and then in the late 80s and early 90s, Clayman and Associates in St. Louis performed the first laparoscopic animal nephrectomy and then the first laparoscopic human. When laparoscopy came about, there were several technical advantages with vision, pneumoperitoneum, smaller incisions that were felt to be a great asset and a contribution to the field. But I use this slide here, which I got from my colleague Indy Gill from Cleveland Clinic, showing that this was a great game changer, but it also can be looked upon as a great seductress. If one were to do a laparoscopic surgery for gallbladder, the incision for extraction is merely 1 centimeter to 1.5 centimeters. So cosmetically and functionally, that's a huge advantage. But what about for kidneys? We had to do more salation to get the cancer or the tumor out. And this was very time consuming and felt to be possibly risky for spread of the disease. I'm gonna just stop that. Hand-assisted surgery was also felt to be an adjunct or a leap between a laparoscopic surgery using tactile sensation and then extracting the specimen through the hand port. And so these are very rarely done now. Very large tumors or very large patients, as seen in this diagram here. So when we looked at conventional laparoscopy, there were several drawbacks. That is a flat image, cumbersome body placement, and more fatigue, I think, for the surgeon. And everything had to really be triangulated. We had to think about very carefully where the instruments would go, and the instruments themselves were very primitive, with opening and closing and cutting and grasping functions. And now, when we look at the advances in robotics, we know that the Da Vinci system, which dominates the robotic market in the world, really has multiple advantages, primarily through its wristed motion, binocular vision, and the small size. As you can see here, this is an 8mm needle driver that is quite small and can do great things. So the most recent adjunct to the armamentarium for the surgeon is the XI robot, which is the 4th generation, which has an 8mm camera. Prior to that, the camera was required to be inserted through a 12mm trocar, and it really made it difficult to change viewing angles. Now the camera can go through any one of the 4 arms that are on the console, and the docking is much easier as the robotic instrument holding arms project over the top of the patient, allowing one to dock from the side, between the legs, over the shoulders for just about any surgical procedure. So then the controversy that is currently somewhat in existence, and I don't think it's much of a controversy at all, is a robotic nephrectomy. There are still many of my contemporaries that would do a laparoscopic nephrectomy, but a robotic partial nephrectomy. And I think that the significant advantages of vision, pneumoperitoneum, dissectability, vision makes this operation safe. And I don't think it's overutilization of the technology. I think it's actually an excellent utilization. But from a practical standpoint, the team that I work with is used to doing robotic surgery, and to switch between a standard lap on one case just because it's a total nephrectomy, I think is a disservice to the patient and also to the team, because with practice and repetition, obviously we get much more facile and better at what we do. So I've pretty much abandoned the standard lap nephrectomy unless the robot is tied up or there's a reason to do a laparoscopic procedure. And this is you can see the dexterity, the visualization. You can still put in a very large specimen into a lap sac and extract it. And therefore, I think my feeling is that the radical nephrectomy, laparoscopically or robotically, are excellent operations and far better than the open counterpart. Well, here's the same slide I showed before, but now instead of being the great adjunct, the lap nephrectomy may be the great seductress, because we do know that nephron sparing is very important. This is a classic paper from the turn of the century or the turn of the millennium, showing that as your GFR goes down, as seen on the left-hand side of the screen, and you lean more towards dialysis, the risk of cardiovascular death and cardiovascular events goes up threefold. So we know that nephron sparing is important. We also know that if one were to take a patient population that has normal creatinine and 2 healthy kidneys, and we do radical nephrectomy, the 3-year probability of developing a lower GFR and changing from CKD 3 to 4 or heading towards dialysis is quite significant. So it is believed and practiced by all of the urologic kidney surgeons that nephron sparing should be the primary discussion point. We talked about size as being a correlate. Here's a nice slide that summarizes renal masses less than 2 centimeters. About 80% of those are considered to be benign or at least of low aggressiveness. And so it's not uncommon for someone that presents with a solid mass that's of this size range to have a follow-up study to look for cell growth or tumor growth, and to not press the panic button and jump into an intervention right away. I'm also a big proponent of not kicking the can down the road, as I like to refer to it. And I don't use patient age as a disqualifier. So we in South Florida have a lot of 80 and 90-year-old retirees that could probably outrace me on a 10-speed bike, play golf better than I, and are more physically fit than the average. And so therefore, we don't use age as a necessarily definitive discrepancy or criteria to not offer therapy. When we get into the 3 and 4 centimeter range, we're still considering this to be a small renal mass, but 4 out of 5 of these tumors are malignant, and therefore this is the more common presentation in our office. So if we know that less than 4 centimeters, 20% are benign, about 60% of those are not of a high pathology score. So only about 20% are potentially very aggressive. And the treatment options that we discuss with all patients that present are observation, excision with either a total nephrectomy or a partial nephrectomy. And I do practice and offer thermal ablation, which we'll get into at the end of the discussion, as one of the treatment options, which is accepted by the AUA as a viable option, primarily for older or less fit patients. But I offer it to all patients just as a discussion point, so that they know that they could have a needle-based procedure in our practice, and that they don't have to go outside of the practice if they chose that. And there's several reasons why one may want to do that. Just to round the corner on the renal mass biopsy, this textbook, which just was published, and I was the co-editor with my colleague at the University of Miami, is several hundred pages long. And suffice it to say, the first chapter is probably the best one, written by Stuart Wolf, talking about the myths and fallacies about renal biopsy. To summarize it for the audience, I don't think that renal mass biopsies cause the spread of cancer. I think there's an issue with respect to false negative biopsies that may mislead one. And if imaging correlates very well with malignancy potential, then I think that many situations don't mandate a biopsy. But there are certain situations, other malignancies, poorly defined tumors that may represent lymphoma, et cetera, where a biopsy would be prudent. So if you'd like more information, I can give you the reference for the book. So partial nephrectomy or nephron sparing is illustrated nicely here. The size of the tumor and the location are very, very important in terms of what the side effect profile may be. So if we're looking at this X-ray, for example, a coronal CAT scan, we can see the tumor in the right kidney as illustrated in a 69-year-old. And this is a 1.3 centimeter mass that grew to 2.2 centimeters in less than 12 months. So in sequence, the steps of the surgery are renal exposure by inserting the instrument, docking the robot, mobilizing the bowel, isolating the renal artery, and then isolating the tumor, cutting the tumor out, and then putting it into an entrapment bag. So this is highly effective for this 2.2 centimeter tumor. And then at the end, after the excision of the tumor, we do what's called a rhinorrhaphy. We use the white plastic clips as sort of bookends to compress the kidney, and we don't tie knots internally. We just use these clips on either side to press the kidney together, and it's highly effective for hemostasis. So this works very well for small tumors, very low bleeding risk, unlikely to convert to an open surgery. But what about for larger tumors? You can see in the cross-sectional pictures here a fairly deep, large left renal tumor. And the approach is the same. And we take out tumors up to 8 centimeters fairly frequently. And there's a cutoff point of when you may want to just take the whole kidney out. And that's related to the patient's overall health status, the contralateral kidney, et cetera. But the steps are the same. Isolate the artery, cut the tumor out. And I'm just going to let this video run for a little bit. But you can see that we're getting down into the collecting system. It's not uncommon to get into the medullary sinus fat. But the deeper that you go, the more risk that there's going to be post-operative hemorrhage, post-operative urine leak, which fortunately, with experience and good rhinorrhaphy techniques, is quite uncommon. Let's fast forward this here. I'm not operating that fast. You can see that we're down into the collecting system. And really with the rhinorrhaphy in 2 layers with an absorbable suture, we can effectively prevent post-op hemorrhage and urinary leakage. But what about technology? If we could get a better roadmap, if we had imaging that could then be projected inside the body, we would have an advantage to understand where we need to cut. And I do believe that the future will involve utilization of technology much more frequently. This is a very new company called Seaver. They're based out of California. And this is showing a 3D modeling of a patient of mine. And I'm going to skip to the actual case that this is relevant to. What this does on an app that you have on your phone allows you to send or upload your imaging, whether it's MRI or CT scan, to a portal. And within 24 hours, they give you a 3D model that allows you to subtract out digitally bones, vessels, cysts, tumors, et cetera. And in this particular case, this was a very complex case with a 67-year-old male with multiple bilateral cysts and multiple bilateral tumors. And the question at hand was, which side do you do first? Do you do both at the same time? Should one kidney be removed and the other one spared? And so this is again the ability to subtract. You'll see the aorta and the arteries are in red. The bronze or gold is the tumor, and right here you see an artery going right to the tumor on the upper pole of the right kidney. On the left side, there were multiple cysts. So on the CT, it was difficult to discern normal parenchyma from the tumors. But with the software, which is very affordable, you can get rid of the things that you don't want to look at. And I foresee the future with robotics and artificial intelligence as incorporating these type of models, which are very rudimentary and crude here, but to allow us to get a better roadmap and do specific surgeries. What about if we didn't want to cut it out? If you can get a probe, like an acupuncture needle, and you could just stick it in there and kill the tumor, you wouldn't have to go through all this modeling. You wouldn't have to go through the clamping of the artery and the ischemia time and the risk of renal failure. So the concept of thermal ablation is illustrated nicely here. If we could get a single probe and we could heat, I prefer heat because I live in Miami, I don't live in the north, but freezing and heat are effective at cell kill. If it could work just like this, everyone would want this. No one would want to be cut open, whether it's a robot or a laparoscope or anything, if you could just do this. So Band-Aid surgery is really the goal. And we have treated close to 1,000 patients with needle ablative therapies in the combined University of Miami Baptist system. And how is that done? Well, the first thing you have to decide is not all probes work by the same mechanism. So therefore, it's imperative that the surgeon or the radiologist understand concepts like blood flow, how fat or insulation can affect these heating, and the conductivity of the tissues. But the goal is to do nephron sparing. And in terms of saving kidney function, if one had a small renal mass, and you could make the argument and assume that this is a truism now, that properly done ablation is equal to a partial nephrectomy from a cancer standpoint, then who in their right mind would ever want to have a surgery to cut something out? It's all about the collateral damage and the risks of adjoining organs that really dictates whether one should offer a patient this as primary treatment or not, in my opinion. So think about this for a moment. We talked about tumor cell growth. If I gave you an example of a tumor that was 3 centimeters in diameter, the volume of that tumor would be 4/3 pi times the radius to the third power. If I add only 5 millimeters to that tumor volume, which you get CT scan reports all the time, what's a couple of millimeters here and there, you've more than doubled the tumor volume when you go from 3 to 3.5 centimeters. So keep that in mind when we're looking at any type of tumor in the body with respect to growth rates. It's volume of tumor cells, not the linear diameters, that's the most important. When we talk about freezing, we know that we can see ice balls. Keep in mind that cryotherapy is effective, but the kill zone is at -40, not at the 0 ice crystal level. When it comes to thermal therapy, we know there's a couple of different things that happen, but basically at 55 degrees centigrade, one will start to see DNA and protein unraveling, and that leads to thermal necrosis. It's not just the absolute temperature that's important, it's how long the temperature is applied for. So therefore, charcoaling and desiccation is to be avoided because that causes insulation. So if we could put a probe or some kind of device in, whether it be non-penetrating, and get tissues to heat to 60 degrees centigrade, you can pretty much kill anything, because tumor cells don't know that their cousin, the normal cell, is right down the block. I'm going to skip over this because it's really more technical than needs to be. I want to focus more on the imaging side of it and have some time to open up for questions. So we're going to talk about ways to potentially make this better, real-time monitoring and alternative energy modalities. This photo really shows one of the instruments that we have available for us in the operating room with a Dyna-CT or a CT platform, which is fluoroscopically based, and I'm going to show you a little bit about that. I'm just trying to get the volume down here. So this C-arm actually has a very wide panel that allows us to do 3D reconstructions in the operating room, and then we do targeting with fluoroscopic control. So it's kind of like Luke Skywalker when he was flying through the Death Star, and he used all this GPS information to find the tumor. One of the things that is important is to plan And then on the telestrator board, we can actually circle the tumor mass. We work with the technician and the archived imaging, and then we can plan a 3D model in order to improve our targeting in this way. The other thing that we do is renal biopsies in the operating room without being inside the CT scanner. So the bottom line is we get CT quality imaging, we get a big working space, and we do this in the operating room with anesthesia so that the patients benefit. We can do breath holding, and we have the surgeon working on the needles himself. Are there situations where CT guidance or this more advanced guidance system aren't helpful? Well, yes, here we see a patient who's lying prone and the tumor is very close to the bowel. So if I were to stick a needle in where the lightning bolt goes, I would have to be really precise in terms of my heat zones to not cause a fistula to the colon. So in these situations, laparoscopy has a role. But when one does laparoscopic exposure of the tumor, as illustrated in the bottom left-hand corner with the blue triangle, it's very difficult to ensure proper needle placement. So here's where electromagnetic tracking comes into play. If one thinks about GPS and tracking both the needle and the ultrasound probe together, we have now technology that allows us to put a sensor under the patient with magnetic coils. So the white board goes under the foam of the operating room bed. The needle itself has a transmitter, and so does the ultrasound probe, so that we can marry the two, the probe and the needle, and track them in space in 3D. So this particular device is a microwave antenna, very simple interface, touch screen, and with pre-existing animal data, we can basically predict how big of an ablation zone over the course of a couple of minutes. Here you see the settings are 100 watts for 30 seconds. I usually like to go a little bit lower energy for a little longer period of time to prevent charring. But here you'll see on the video screen up top, the red zone is where the target of the tumor should be. And this is just illustrative outside the body, where we can target the needle laparoscopically inside the body and have a more precise biopsy and ablation setup. So we put a sensor probe on the ultrasound probe. We have the needle itself, and I'm going to show you a quick video that illustrates how this is done. Just in terms of timing for the audience, I know we're going to have some time for questions and answers. I've got about 5 more minutes of this video and my closing slides, and I know we covered a lot, but I do want to handle some questions, which I'd be happy to do in a few moments. So this concept of the electromagnetic tracking, I think, is useful for all surgeries. I think once you get a taste of how it works inside the body and see the precision, there are some advantages to doing this over what I consider to be the gold standard, which is the partial nephrectomy. So this is very new technology. It has a utilization in other disciplines such as neurosurgery, general surgery for liver tumor ablation or tracking, doing biopsies in other places. But this is now a surgeon-controlled biopsy technique or placement technique, which heretofore was only available to radiologists. And I think as we work together, this technology, just like cell phones and other devices that we take for granted now, this is going to become a bigger part of our armamentarium as we go forward. So in summary, we talked about a lot of things in just a half an hour. Renal masses, not all of them are malignant, and there is a size correlate that I think you should keep in mind. The gold standard is, in terms of treatment, is to make an accurate diagnosis and to do nephron sparing. And if that means don't touch the patient at all or only do a biopsy, that would give you the best option to preserve nephrons. Thermal therapy using various heat or freezing techniques such as radiofrequency, laser ablation, microwaves are they're in the armamentarium currently. And I think that they're underutilized. And part of that is because surgeons don't like to have radiologists do things for them in some instances, and maybe radiologists only have one tool available to them, and they'll stick a needle into things that they're asked to do. And I think that imaging and probe placement are always going to be paramount to successful cancer therapy, whether it's in urology, the kidney, the prostate, or in other disciplines. So at that point, I'd like to stop sharing my slide, and I think I can ask the moderators to see if there are any questions that were posed by the audience.
Dr. Hakim, you're on mute.
I just noticed that, Dr. Rivas, it always happens at least once in every conference. Thank you so very much, Dr. Leveillee, for that very insightful presentation. I know that the group will have some questions for you. Please remember, for today's Q&A session, you may ask your questions by using the Q&A feature located at the bottom center of your screen at the right of the chat feature. Please type your questions there and click submit. Dr. Rivas, would you do us the honor to walk us through this?
Thank you, Dr. Hakim. I almost started talking on the mute button also. So Dr. Leveillee, thank you for an amazing talk. I just couldn't, you know, my dad fortunately had a renal cell carcinoma that was fairly large back in the 90s. And thinking technology-wise, what's available today and what's available then, you come to think about what could have been and what could matter. But it was dead on what you said about nephron sparing, because immediately thereafter he had to go on dialysis. And so I'm always wondering what do we, as on the primary care side, would have to do to try to catch these things earlier. I mean, by the time we get it, it's so big, there's not much to do. And, you know, what are your, can you share with me your pearls?
Yes, absolutely. I think that's an excellent point. And other than visiting the emergency department and getting a body scan, I think a urinalysis has a big role here. The hematuria workup involves looking at a well obtained or a properly obtained specimen, and then it has to go to the lab and be centrifuged and count the red cells. I think too often we rely on a dipstick, a piece of chemical paper, to look for urine that has blood or pus in it. And those dipsticks have some limitations. So I think if someone has a true blood in the urine on a dipstick, they should then get a formal urinalysis. And then at that point, the guidelines recommend upper tract imaging and referral to a urologist. So from a primary care standpoint, since I work with people here at Baptist very closely, I tell my colleagues, look, if you get somebody with blood in the urine, whether they see it or whether they have it on a formal UA, go ahead and order a contrasted study, a renal function panel, to give us some kind of a headway. And not all blood is cancer related, as you know. So we're looking for stones, we're looking for sources of infection or obstruction. I think ultrasonography has a role here to screen for things if someone doesn't have blood in the urine, but it can miss things as well. So I think that if I had limited resources and I was running a clinic for patients from the family medicine side, I think an annual urinalysis and a chem profile would be bare basics. And then if you had an imaging available to you, ultrasound is very inexpensive and can screen for quite a few things like cysts, stones, and tumors. And then if there's a finding, then I think referral on to a specialist at that point.
Thank you, doctor. And going back to the robotic surgery, you make it look so easy. And and you know, it makes you feel like you want to go in there and play video games like I play with my boys. But at the end of the day, it's not. It takes a lot of work. I know GYN oncology talks about they see a level of growth in speed after 80 surgeries on the robot. Would you say that the that would be same or similar, or is it more difficult on the urological side?
That's a great question, and I'm not the best person to answer that. That would be like asking someone how hard it is to ride a bicycle when they were around when the wheels were made out of stones. We started doing laparoscopic surgery in 1993, 94, and then the hand assist actually came about the mid 90s, and the robots came on the scene around 2000. And this is the fourth generation of robots. So the first ones were very painful to just put together. The ergonomics were bad. And so for me, my personal learning curve is 25 years, right? But I've been using the robot since 2001. And so having taught others in fellowship and taught others at training seminars, I think that prior experience would also dictate how many cases it takes. So whether it's 50 cases or 80 cases or the same case 10 times in a row with a good mentor, there's no consensus as to how many, but certainly repetition precedes perfection. So I think it's more than just one or two. From a credentialing standpoint, the hospitals usually want to have the surgeons do the cases, but they don't have very strict criteria because we all have different backgrounds.
Thank you, doctor. There's a question that says, if one cannot have kidney surgery because of other serious medical problems, what other treatment options are recommended? I think this is where you were speaking about the thermal option.
Yeah, so a needle ablation, when it first was introduced, many physicians were skeptical. And many of those physicians that were skeptical had more gray hair than you and I do. And sometimes it takes a long time for people to understand the limitations of, don't be so harsh to judge. And so the guidelines panel initially said, well, these are only for the infirmed patients who are going to die anyway. And my feeling is that if it works and it's done properly and you understand how it works, why not give it to a 40-year-old and do an ablation that they're going to benefit? They're going to stay out of work for 2 days and go back to work instead of having all their guts moved around and have, 2 or 3 days before they can pass wind and eat a sandwich again. So I've always been a firm believer that when you understand how something works, you can get a good result. If you don't understand how it works, or you misuse technology, you're going to get a bad result. We just had some technical problems with my brand new Macintosh computer because I'm naive to this one. It's a great computer, but if I don't have practice with it, I'm gonna not do well. So to get back to your question about somebody who's too ill to have surgery, I guess the details would have to do, is this a temporary illness, such as recent cardiac stent or recent cardiac bypass, or recovering from a pneumonia, or getting over COVID? Those things can be short-lived, and maybe there's improvement down the road where someone might be a candidate for an optimal therapy. So I wouldn't reserve needle ablation or thermal ablation just for the hapless and those that have no alternatives. I would use the needle ablation as part of the armamentarium based on the tumor size and location. If someone is so ill that they can't have surgery, then maybe they might pass or die from some other disease process, because most kidney tumors are slow growing.
Doctor, normally the patients that come in from robotics, usually the time spent in the hospital, obviously it all depends on each experience of the surgeon, but the actual time spent, anesthesia time, can you go over a little bit of that, of how,
Sure.
how that benefits?
Yeah, let's take an index patient, someone who is otherwise healthy, BMI of 30, may have 1 or 2 medical problems, diabetes or hypertension. So no extremes here, but an index patient, which is what walks in through your door. If they have a 3-centimeter renal mass, they come into the hospital the day of surgery. So all the preparation is done beforehand. We don't do a bowel prep. We don't do any prophylactic antibiotics except for right before they go to sleep. They all get a general anesthetic. It takes about, I would say 45 minutes to an hour just to put them to sleep and position them on their side so that there's no pressure point problems or orthopedic injuries. And then putting the instruments in, docking the robot, finding the blood vessels, cutting the tumor and sewing it back together. For me, it takes 2.5 to 3 hours. I don't own a wristwatch. I don't rush. It's too important to try to do things fast. But if you're fast and you can do it better and faster, then all hats off to you. But an average OR time would be 3 to 4 hours, including anesthesia. And then we give our patients liquids the night of surgery. We encourage early ambulation. We often use parenteral narcotics for the first 24 hours and then switch over to orals. We've toyed with non-steroidals and intravenous Tylenol and other types of analgesias to try to shorten the hospital stay. But by day number 2, most people have their catheters out, they're passing gas, and they're advancing their diet, so they go home on day 3. Once they leave the hospital, it is extremely uncommon to get a narcotic refill or for someone to ask for one. And I think a lot of that had to do with our understanding of this opioid crisis, which I do believe is real in the United States. And if someone's not on narcotics, they can drive a car because I'm not legally giving them the permission to be drunk on the roadway. And so most of our patients are back driving themselves to their post-op visit 1 week later. I tell them to avoid golf and weightlifting or climbing a tree if you're a fireman for about 4 or 5 weeks. But normal people activities, I'd say within 2 weeks is pretty normal.
Thank you, doctor. And when the patient, let's say, an international case, comes in from abroad and they have to undergo a procedure, when is it safe usually for them to travel or return back to their country? Like ortho, they usually like 10 to 14 days. What would be the normal amount of time if somebody has to travel back?
I think that's a great question. Again, if we go back to the index patient where there's no post-op complications, it's pretty much standard. I think that time frame fits well with us. I caution people if they have to fly for more than like 2 hours, that they're at a higher risk for blood clots. So I've had some patients come from Europe or from South America, so we put them on oral antiplatelet therapy, not just aspirin. Tell them to walk, get on the plane, stay hydrated. But I don't think there's really any contraindications to air travel. I think 10 to 14 days is very reasonable.
And doctor, this is one of the questions we always like to say, because we're blessed, right? I think at Bethesda there's 1 or 2 robots, correct, for Bethesda East and West. But I think in the whole system we have about 18 to 19 robots for Baptist Health South Florida.
Right.
And I remember traveling to Brazil, and they told me they had 14 in the whole country in Brazil.
Yeah.
And so, but it's not always available. And so what I think the part of teaching, the teaching point here is also, and us as medical directors, when we have to deal with these insurance companies, is when is it that the robot is not an option? Is it, you spoke about size of the tumor. When is it that the actual, you're going to have to revert back to an open? Is there a size parameter, or what's your take on that, please?
Yeah, I think that I can give an example of just this past week. We had a gentleman that I would say he was about 5'6", maybe 280 pounds, so 110, 120 kilos. So his body mass index was up there. And he had a 6 centimeter posterior renal mass, and we were going to do a partial nephrectomy. I sent him for a renal biopsy. He went home from the hospital, and 48 hours came back with a retroperitoneal hematoma. So the tumor biopsy was papillary renal cancer, which is not highly effectively treated with chemotherapy or oral immunotherapy. And he had a normal kidney on the other side. So with that scenario, I said, this is just not a good robot case. Everything's going to be stuck. We're going to have a big hematoma. So we did him open. 2 weeks ago, we had a similar situation with bilateral tumors 12 centimeter right kidney, 4 centimeter left kidney, and then a 4 centimeter left adrenal tumor. So we did those open because it was just going to be more expeditious to do everything under one anesthetic. So size does have some impact here. Prior surgeries, let's say we were going to do a nephrectomy for a transplant kidney where there's lots of scar tissue and we're concerned about vascular injury. A renal vein thrombus where the tumor goes into the vena cava and up towards the heart. I think those in my hands are still better treated open with a vascular surgeon helping in case we have to do a IVC graft or do something like that. So they do happen. And we see a high volume of renal masses at our little Bethesda hospital. And I have to say, I hope it's because of our reputation. I hope it's because of our experience and also the location that we're in. We're kind of uniquely situated between West Palm Beach and Boca Raton and Miami. And so we're kind of in a nice little niche here, representing the northern part of the Baptist health system.
Yeah, I think it's time that we do a little plug here for Bethesda East and West. So you practice at both hospitals, correct, doctor?
Yes, but actually, if you have some pull with the administrators, we actually only have one robot, and it's at East. So robot time is occasionally a problem, but I think the hospital has devoted a lot to the urology program for prostate and kidney cancer, and so I think I just run out of hours in the week, not hours on the robot. I mean, they would accommodate me, but as we get bigger and busier, then we will need more machinery.
We're going to work on that. And your area, it's prone to international travel, right? You have an airport close by. You have international airports, multiple in the area. Yeah. And so it makes it, and not just that, but even folks coming from the Bahamas, there's even a ship that comes back and forth. So there's
there's I think from West Palm Beach, we're about 15 minutes away from the airport, and from the port of West Palm to Bimini is 55 minutes with twin Yamaha 250s.
I'm gonna have to try that one. You know, Dr. Leveillee, we really respect your time and we thank you. It's not every day that we have a luminary on board with us. I can say this to all those folks that are here. You are the urologist and the specialist of my family, taking care of my loved ones. And I'm here to tell everybody that this is a person to trust. The training, when your urologist tells you, I'm going to send you to my teacher, that's exactly what we did. And we wound up with Dr. Leveillee. And we thank you for everything you've done to help my family.
You're very welcome. It's my pleasure.
I think we're getting close to the time, but I think that the last question I have for you is, you know, everybody's afraid to possibly go be checked out and for something to happen or getting a bad diagnosis or something like that. For what it seems and what you're telling me, the earlier the better. And why check yourself out first? I'm not talking about some of my international patients that show up to Baptist and they tell me, I want a PET scan. Dr. Hakim, I want a PET scan from here to there. I'm like, what do you have? I just want to get checked out. But at the end of the day, you know, it's all about the primary care physician looking out and then every other physician looking out and communication. And so what would be your best if we were to have a patient to come to you, the basic needs that you would need other than consult notes or any other surgeries? What are the things that you're looking for if your patient's coming from another country that they have to bring with them?
Yeah, I would say the number one thing would be a high quality, non-contrast and contrasted intravenous CT scan. That would be my number one thing. We can tell a lot more with CT in terms of tissue perfusion, density changes to distinguish high density cysts from solid masses. We can measure the Hounsfield units. We can look for calcifications. We see the blood supply clearer than on an MRI, which sometimes can be a little fuzzy. I think if I was in the ortho department and I was going to look at knees and joints, the MRI is superior. From a urologist standpoint, the CT is superior. It is our stethoscope. It is our eyes inside the body. And as we get better and faster software, those images I showed you with the digital subtraction will be commonplace. You'll be able to put that on your iPhone and show your patients, this is where your tumor is, and give a real good teaching tool. But more importantly, incorporate that into the console for the robot, which is being done now, but it's multiple interfaces. I just see the future surgeons having a dotted line on here's where the artery is, and they go get it. So that's going to make things faster and better. But maybe another 10 or 15 years. We don't know.
Well, I can't wait for the next talk when you start talking about stones and urinary calculi, because that's just again, your knowledge is incredible. Dr. Hakim, I give it over to you. Thank you, Dr. Leveillee.
You're very, very welcome, Dr. Rivas.
So much, Dr. Rivas. On behalf of Baptist Health International, I would like to thank you, Dr. Leveillee, for your incredible presentation, and to all of you for participating today and for attending. If you have additional questions about today's presentation or any of the techniques that Dr. Leveillee uses, please feel free to email us our PHI webinars@baptisthealth.net or call our direct number 786-596-2373. We will make sure to respond to you promptly by getting Dr. Leveillee's suggestions and recommendations. We look forward to seeing you at our next quarterly medical lecture scheduled for Wednesday, August 18, 2021. Please stay safe, and we shall see you again. Thank you so much, Dr. Leveillee.
You're very welcome. My pleasure. Thank you all for listening, those that stuck around to the full 55 minutes.
Thank you.
Thank you, doctor.